Preventive Medicine, a Quantitative and Personalized Evolution of the 19th Medical Discipline, number 1413, October 31, 2025. Gerald C. EclaireMD Foundation. Category: General. Introduction. Throughout my medical research journey, I have often asked a simple question: why does modern medicine wait for people to become sick before offering help? Hospitals are filled with treatment departments, but very few focus on prevention. In the United States, preventive medicine mainly exists in public health agencies or academic programs, rarely inside hospitals. Yet prevention should be the first and most important mission of medicine. After 16 years of studying my own body and collecting over 4 million pathophysiological data points, I realized the classical definition of preventive medicine must evolve. It must move beyond population averages and static statistics to become quantitative, dynamic, and individualized. This is why I developed Viscoplastic Preventive Medicine. VPM, a fusion of physics, mathematics, engineering, and clinical pathophysiology that transforms prevention into an exact science. Why traditional preventive medicine falls short. Traditional prevention focuses on vaccines, screenings, and lifestyle education, valuable, but limited to population averages. A physician might say walking 10,000 steps per day lowers diabetes risk, or keeping blood pressure below 13,080 mm of mercury reduces stroke risk. Yet these statements describe groups, not individuals. My own experience proves the flaw in averages. Over 3 months after my stroke, I recorded more than 10,000 blood pressure readings. Only 0.2% exceeded 130 mm of mercury, and none surpassed 150 mm of mercury. Statistically, I was not hypertensive. Yet on June 21, 2025, I suffered a hemorrhagic stroke, caused by an acute blood pressure surge triggered by emotional stress. The root cause was not chronic hypertension, but long-term microvascular damage from 36 years of type 2 diabetes. Traditional methods could never see the cumulative internal stress that had built silently for decades. Why prevention sits in agencies, not hospitals. Many readers ask why preventive medicine in the U.S. mainly lives in government agencies, academic programs, or public health departments rather than hospitals or private practices. My answer is simple: it is the economic incentive structure. Hospitals, insurers, and pharmaceutical companies operate within a capitalist framework, where financial sustainability depends on service demand. Their business models rely on caring for large patient populations. Furthermore, chronic disease patients require lifelong medication and continuous follow-up care, which helps sustain the current economic structure. Furthermore, their multiple complications serve as major sources of income for healthcare institutions. Although the extent of this impact varies across countries and healthcare systems, I have come to understand this reality through my own personal experience. In contrast, successful prevention reduces medical demand, a noble goal medically, but one that conflicts with short-term business incentives. Having studied economics, marketing, and business administration, and served as CEO of a major public technology company on Wall Street for 8 years, I recognize this instinctively. I am not criticizing individuals, but describing system economics. With 16 years of self-study in medicine and over 1,400 research papers published, I see the dual reality clearly. Prevention is morally and medically correct, but economically inconvenient in today's profit-driven system. Most clinicians and scientists understand this truth. They believe in prevention, but work in a system paid primarily for procedures, admissions, imaging, and prescriptions. When prevention succeeds, it reduces clinic visits, medication use, and hospital admissions, cutting into the very revenue streams that sustain the current healthcare ecosystem. Insurance adds another barrier. The insurance industry needs a large number of subscribers to sustain its business. For example, if one sick patient requires the contributions of 50 healthy subscribers to cover the cost, the company would need another 50 subscribers, 100 in total, to maintain its revenue and profit margin. This is why insurers focus on the averaged picture of the mass population, rather than on individual cases. Besides, insurance plans last only 1 year, and members switch frequently, so insurers rarely keep the same clients long enough to benefit from long-term coverage. To them, prevention appears as a cost today, with uncertain savings tomorrow, likely realized by someone else. As a result, most insurer prevention programs focus on short-term screenings, not continuous, personalized management like my VMT and TDA results shown. Pharmaceutical economics add another huge dimension. When patients manage their health through lifestyle and self-discipline, medication demand drops, but most people struggle with weak willpower and long-term consistency, making real prevention rare. I deeply respect the scientists who create life-saving drugs and salute their contributions to humanity. Still, the macroeconomic reality is clear. Industry revenue grows with chronic medication use, not with permanent remission through lifestyle control. Inside hospitals, leaders know prevention is correct in principle, and most clinicians believe in it. But in practice, no one is paid to take ownership of prevention at scale. The system rewards treatment, not the avoidance of disease. That is why some doctors raise their right hand to take the Hippocratic Oath, while keeping their other hand tightly on the money in their pocket. Here, I use a visual metaphor to highlight the hypocrisy within the healthcare system, showing how financial incentives can sometimes override the true spirit of healing. Thus, prevention is pushed outward, to public health agencies and community programs, because it does not fit within the fee-for-service framework that drives hospital operations. I am not trying to be cynical, but my writing truly reflects what I have learned over the past 35 years. Lessons paid for at a great price, with my own health and almost my life. I have seen this firsthand. After attending hundreds of medical conferences for more than a decade, I decided to stop submitting to journals or attending events. I still respect science and peer review, but my mission shifted to help real people before they become patients. I now share practical, data-driven methods and findings through public platforms like YouTube, where anyone can apply them immediately if they want to be helped. If prevention is under-incentivized within hospitals, I will take it directly to the public. This is now my personal mission. Even if I can save only one life, it would make every effort worthwhile, because behind each patient are many loved ones whose lives are also changed. Building a math-physics-based medicine model. My engineering background in dynamic plasticity at MIT inspired me to see the human body as a viscoplastic system. Professor Norman Jones, my PhD mentor, taught me how materials absorb and release energy under repeated loading. Biological tissues and organs behave the same way: they deform, recover, and eventually fail once stress exceeds tolerance. This principle became the foundation of my viscoplastic medicine theory, VMT. I applied it to diabetes, cardiovascular disease, kidney disease, stroke, dementia, cancer, and aging. Biomarkers such as fasting glucose, body weight, blood pressure, visceral fat percent, walking steps, and sleep hours act as input stress by number health outcomes or the output strain. The energy stored in this system reflects cumulative biological stress. The goal of prevention is to maintain stability by minimizing total viscoplastic energy. Continuous data collection, feedback, and adjustment are essential. My iPhone-based medical AI software, Chronic, calculates strain, stress, and energy in real time, giving instant preventive feedback and insight. The role of topology and geometry. After my stroke, I expanded my research tools into the topological data analysis, TDA, domain. While VMT quantifies energy, TDA defines the geometric structure and connectivity of biomedical data. Large, irregular TDA shapes signify instability and stress. Small, compact clusters represent balance and health. When I compared VMT and TDA, both told the same story. High energy always matched larger, scattered geometric areas. Low energy matched smaller, tighter clusters. This parallel between physics and geometry confirmed that my observations reflect real humans' pathophysiological phenomena, not mathematical artifacts. Personal application and outcomes. In 2010, my body was in crisis: obesity, type 2 diabetes, hypertension, dyslipidemia, neuropathy, and retinopathy. By 2010, I was near kidney dialysis. No medication could save me unless I changed my lifestyle completely. Since 2010, I began to track daily data on weight, glucose, pressure, food, sleep, walking, and stress. Using physics-based models, I discovered relationships missed by traditional statistics-based methods. For example, every 10% reduction in my visceral fat lowered my fasting glucose by about 8%, and improved blood pressure elasticity. Through these consistent quantification and adjustment efforts, I reversed my diabetes, stabilized cardiovascular health. No further cardiac episodes after my fifth event in 2004, and extended kidney function far beyond medical expectations. And all of my kidney biomarkers have been normal over 1 decade. These results came not from luck, but from disciplined application of science to self-care. Core principles of quantitative preventive medicine. 1. Personalized. Each body has different tolerance limits, like materials with distinct yield strengths. My model normalizes metrics by age and physical capacity. 2. Dynamic. I measure energy flow over time rather than static snapshots. Daily glucose fluctuations, even within normal ranges, carry measurable stress energy. 3. Self-managed. With smart devices and simple visual tools such as strain stress diagrams or energy bars, anyone can learn to interpret their own health and manage it proactively. The structure of modern medical disciplines. In Japan, the Medical Specialty Board recognizes 19 primary disciplines, with preventive medicine, also known as generalized medicine, as the 19th. Globally, including subspecialties, there are about 28 fields, ranging from internal medicine, surgery, and neurology to endocrinology, cardiology, nephrology, and infectious diseases. Among them, preventive medicine is unique. It is the only one dedicated to avoiding disease rather than treating it, bridging clinical practice, public health, and personal behavior, making it the natural foundation for my quantitative health research. I watch Japanese TV dramas for relaxation and entertainment, with their English subtitles. From these, I learned that in Japan, the Japan Medical Specialty Board officially recognizes 19 primary clinical specialties, with preventive medicine, referred to as generalized medicine, synthesized or comprehensive medicine, as the 19th discipline. When subspecialties are included, modern medicine globally consists of about 28 major departments that encompass the full spectrum of human health. These 28 medical departments are: 1. Internal medicine, 2. Pediatrics, 3. Family medicine, 4. Surgery, 5. Obstetrics and gynecology, 6. Psychiatry, 7. Neurology, 8. Ophthalmology, 9. Otolaryngology, ENT, 10. Dermatology, 11. Orthopedic surgery, 12. Urology, 13. Anesthesiology, 14. Radiology, 15. Pathology, 16. Emergency medicine, 17. Physical medicine and rehabilitation, 18. Oncology, 19. Preventive medicine, 20. Nuclear medicine, 21. Allergy and immunology, 22. Endocrinology, 23. Gastroenterology, 24. Pulmonology, 25. Cardiology, 26. Nephrology, 27. Rheumatology, 28. Infectious diseases. Among these, preventive medicine is the only one that focuses on avoiding disease, rather than curing it after onset. It bridges clinical practice, public health, and individual behavior, making it the natural foundation for my medical research, and for the future direction of quantitative health science. Real-world validation. I have published over 1,400 single-authored papers across 50 medical diseases or fields, from diabetes, CVD, CKD to cancer, sleep, and aging. Consistent viscoplastic energy patterns appear across all datasets and conditions. For example, in my 10-year stroke study, 4 stressors, systolic BP, visceral fat percent, exercise, and sleep apnea, predicted my hemorrhagic stroke months in advance. Afterward, I tracked recovery energy, which followed the expected decline, recovery, curve. I also studied post-stroke memory and cognition, areas rarely quantifiable due to their complexity. Neural network AI analyses and topological geometry. Analysis of aging and cancer risk also produced patterns nearly identical to my VMT energy findings, confirming that both physics-based, math-based or AI-based systems converge on the same biological truth. Integrating mind and body. My recent stroke taught me that emotions and physiology are inseparable. The event was caused 53% by chronic vascular stiffness, and 47% by acute emotional stress. Emotional surges trigger sympathetic overdrive, raising pressure and straining fragile vessels. Therefore, I include mental regulation in my preventive model. Through mindfulness, emotional awareness, and balanced living, physiological metrics like pulse, pressure and heart rate variability naturally improve, reducing internal stress energy and restoring system stability. I have also written from 40 to 50 research papers on abnormal psychology and borderline personality disorder, BPD, applying my VMT model quantitatively to psychological domains. Redefining preventive medicine. Viscoplastic Preventive Medicine, VPM, is a quantitative, self-managed, system-based discipline applying dynamic plasticity, nonlinear energy flow, and topology to human health. It measures and minimizes cumulative energy to prevent disease and restore balance. This framework unites pathophysiology, engineering, and AI into a measurable, predictive science, transforming prevention from theory into action. Looking ahead, the future of medicine lies not only in hospitals or labs, but in individuals who understand their own bodies through data. I believe VPM represents the next evolution of preventive medicine. Merging self-monitoring, digital tools, such as iPhone, Apple Watch, or Oura Ring, and real-world physiology. Anyone can collect and analyze their own data, on sleep, steps, stress, glucose, or food, and learn to interpret it through simple scientific logic. Prevention is both education and empowerment. When people understand their bodies, they become their own first doctors. Conclusion. An interesting comparison between Japan and the United States highlights the proportion of preventive medicine doctors within each nation's total medical workforce. Japan, approximately 0.3%, about 1,000 preventive medicine doctors out of 320,000 total physicians. United States, approximately 0.9%, about 9,000 preventive medicine Doctors out of 1 million total physicians. Viscoplastic Preventive Medicine embodies my lifelong mission to merge mathematics, physics, engineering, and medicine into one framework. It is deeply personal, born from my own illnesses, yet universal in its application. The human body, including all organs and tissues, is a viscoplastic structure, constantly adapting to internal and external forces. If we can measure and manage these forces in real time, we can prevent failure before it happens. That is the essence of prevention, and the purpose of my life's work. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights belong to the author. Gerald C.